Good morning. My name is Michael Higgins. I am a professor and the director of the Masters of Athletic Training program at the University of Virginia. I would like to thank the National Athletic Trainers Association for allowing me to present for you today during this virtual conference. Today, we're going to talk about proximal dynamic functional stability for the treatment of lower extremity pathology. So what is proximal exercise? We're going to talk about some different ways or different definitions of proximal exercise. So proximal control can be considered a regional approach because you're utilizing a nearby proximal joint to control another joint's dynamic movements. The trunk and hip can affect lower limb alignment, which has implications for therapeutic exercise design and possible injury prevention. And this has been shown in some of the research out there that looks at trunk and hip control for patellofemoral problems and even for ankle instability problems. Also, for proximal exercise, it's utilizing the muscles and joints in the kinetic chain that are proximal to the joint that ultimately will be influenced by the applied intervention. Again, the hip or trunk on its effect of the knee or the ankle. We're also influencing dynamic stability of the lower extremity by focusing on the function of the trunk and hip. So a lot of the exercises we'll be talking about today are trunk and hip exercises and how they affect the joints lower to that, such as the knee and the ankle. What is functional stability? So we talk about proximal exercise, and then we're going to talk about functional stability. Functional stability incorporates these 6 factors: motor control, isolated strengthening, endurance training, proprioception, dynamic stabilization, and multiple planes, and neuromuscular control. So we'll talk about each one of these and how they are encompassed in our exercise program, which we're talking about today. If you put them together, what is proximal functional dynamic stability? This can be defined as the ability to coordinate the body to produce a desired outcome and return to the previous resting state as efficiently as possible. This concept relies on the coordination between local, regional, and global systems, which we'll talk about in the next couple of slides. And then performance movement stability can be achieved by integrating parts of the kinetic chain. So we're going to be looking at how parts of our body are connected. We may not think they're connected, but if you look at Thomas Myers, and if you look at regional interdependence, we're going to see how these come into play and how they affect joints above and below what we're talking about. So if we look at exercise or rehabilitation techniques, we can look at isolated, regional, integrated. Isolated or local is the idea of administering therapeutic exercise using muscles and forces to produce strength gains in the muscles surrounding the pathological joints. These are isolated exercises mainly for strength gains. We can also utilize these exercises for motor control. We also look at a regional approach. So it's a program focused on the area surrounding the pathological region that can influence the pathological joints, biomechanics, and neuromuscular control strategies. And then we also have the integrated. An integrated approach is using a specified strategy to coordinate limb movement with trunk motion or stability and stability to produce the desired motion pattern. So it's not incorporating a total body coordination to work with each other. We look at local or isolated exercise evidence. What's the evidence for that? In some instances, an individual may not have the strength in a specific muscle to accept the load. So then you have to start off at the basics and start strengthening that muscle. Also, strengthening still has tremendous value locally, as we stated before, that if the muscle isn't strong enough to accomplish the task that you require of it, then you're going to have to strengthen that muscle. But also there's a question if strengthening is a true linear relationship to movement quality. There is evidence that shows that if you strengthen specific joints, it may not transmit or translate to increased movement quality just because you have increased strength. There's also evidence regarding hip-specific exercises for both increasing activation as well as strength at the hip. Now, if we look at the regional exercise evidence, there's evidence to suggest that hip-focused exercises improve early outcomes after an ACL reconstruction. There have been multiple systematic reviews that report the effectiveness of hip-focused program reducing pain, improving strength, and improving biomechanical outcomes after surgery or for rehabilitation of patellofemoral problems, knee pathologies, and ankle pathologies. And as I said, most of the evidence for the regional approach to utilizing the hip is to alter lower extremity mechanics that are found with the patellofemoral research. So a lot of times this has been instituted or focused on by Powers and his associates early on in their approach to patellofemoral exercise. And then we have an integrated approach. The integrated approach, you can look at lumbopelvic complex and trunk focus exercise programs. They may be the element that ties the efficient movement from the upper extremities to the lower extremities. So when we talk about functional movement, this might be the best way to achieve that goal. We know that hip-focused programs can make changes locally and regionally to influence performance activity. Then an integrated rehab approach should be the goal. So a lot of times if you want to improve performance with our athletes or have our patients perform a certain task, the influence is usually just don't move one joint. It's going to be a multi-joint approach and a multifaceted approach. And is this a better approach to rehabilitation, the integrated approach? We're not sure. We think it is, but there is evidence lacking in the literature to support this approach. So if you look at evidence for the proximal exercise for lower extremity, you look at what's in the literature right now, it may help decrease the incidence of ACL injuries, such as with your motor control programs for ACL prevention programs. It's been shown to be effective in the treatment of patellofemoral problems. Hip strengthening and neuromuscular control exercises have shown decreased risk for lower extremity injury. There's altered gluteus medius activity in ACLR patients with weight-bearing exercises. It's been shown to be decreased with those individuals. And you also utilizing proximal exercises that increase jump landing efficiency when you strengthen the hip and core during those types of movements. Also, it's been shown that core warm-up, all right, has decreased the incidence of lower extremity injuries. Abdominal core activation, right, enhances hip muscle recruitment in the clamshell, the hip abduction, and the prone hip extension exercises. There's co-activation of abdominal and hip muscles when performing hip exercises, and hip extensions may play a role in minimizing hip abduction during jump landing. So a lot of times you can see that in the research that has been shown in these instances that utilizing a proximal exercise approach can have an effect on the joints and the muscles distal to that area of exercise or the area that you're concentrating on during your rehabilitation program. So if we look at function of the lower extremity, the proper function of the post-lateral hip musculature during single limb weight bearing is essential to provide stability for lower extremity motion. And this is very important to understand when we look at, say, a drop landing, or we look at a valgus motion, or we look at a dynamic knee valgus or medial knee displacement during running or jumping, right? So we look at specifically the roles of these muscles are able to stabilize the pelvis in the sagittal, frontal, and transverse planes to maintain a level pelvis and control 3 planes of motion between the pelvis and the femur. And this is important that we realize this because we look at that top-down approach and we look at how well, if we can control our pelvis, we control our trunk, and it has a pretty good dynamic effect on the lower extremity. It's important to note that these muscles function primarily in an eccentric manner during weight-bearing activity. And this is an approach we're going to look at later on when we talk about exercise, how we should emphasize eccentric muscle activation and eccentric control during our strengthening programs. So if we look at the femoral rotation on the patella, usually the patella really a lot of times doesn't move on the femur. It's the femur that moves on the patella. If you look at this MRI here, you look at how nice straight that patella is and sits right into that groove. And then we have that rotation of the femur, and you can see how that patella gets off-centered out of that groove, causing you to have problems. So it's a lot of times if we control femoral rotation, right here, when we internally rotate that femur, you can see how that affects the patella. And that's the biggest thing we want to look at here, how can that turn into a pathological condition when that femoral, you have that femoral rotation during your exercise or during your functional movement patterns. So if we can control this femoral rotation, we'll be better off with, say, our squatting test or stepping test, even running. And then if we want to incorporate human performance movement into there, we can do that as well. So we look at the thoracic spine influence on the lumbopelvic hip complex. The thoracic spine can play a major role in function of the lumbar spine. So we look at if we have a tight thoracic region or if you have a kyphotic thoracic region, that can affect lumbar spine motion, and that can affect, which in turn affects hip motion. Also, we can affect core or trunk stability. So if this area is tight, we're going to have to get motion from our lumbar region to pick up for that. And then if our lumbar region still stays tight, then we're going to have to get motion from somewhere else, such as our hips or our pelvis, which can cause to have problems. Also, this might lead to asymmetrical rotation, which will cause problems in the lumbar spine and in the hips with your throwing athletes or even athletes that need to get that symmetrical rotation within their pelvis when they need to perform their sports or perform their exercises that they need to do. So it's important to look at how the thoracic spine can play into lumbar and hip dysfunction. So these are things that we need to investigate when we're talking about our rehabilitation programs or when we design our programs for our athletes. So if we look at the hip-spine relationship, and this is an important relationship that we need to discuss. We look at some of the force couples that are around this area. So if we look at where the rectus will come into play here, right? And then we look at the erector spinae muscle group, which causes the anterior rotation of the pelvis, or then we look at the rectus abdominis muscles, which come off of the front of the pubis, and then we look at the hamstrings come off the ischial tuberosities, cause a posterior rotation of that pelvis, and we look at the stability in this area. And also, too, when you look at your athletes, that if somebody has a tight hip structures, they may have to get that motion from their lumbar spine. And this is usually commonly seen in rowers a lot of times, that you'll get a tight hip complex and they end up with back pain because they have to get more motion from their spine than they really want. So they're using their spine for mobility versus stability when they're rowing. So it's a lot of times important to look at how the lumbar spine is affected by the hip. And you can see here, patients with a history of back pain tended to move at their lumbar spine during early forward bending and had a significant lower lumbar hip flexion ratio during middle and forward bending. So that's going to initiate that flexion from their spine. So hip disorders can also cause back and pain, back disorders and pain that you look at. A lot of times people with poor hip mobility or with total hips, when they're going in before total hips, they have an abnormal gait, which causes them to have a lumbar spine pain. And you have decreased straight. If you look at someone who might have a decreased straight leg raise, that might be due to poor core and pelvic stability. So you may want to look at stabilizing their trunk and redoing their straight leg raise to see if that can be effective. And a lot of times too, when you do especially if you're an FMS, an individual looks at straight leg raise as a factor or as an assessment. You may want to look at stability of their trunk while they're doing their straight leg raise. And it may cause you to have some different results from that test. Okay, so if we talk about proximal and distal exercise emphasis, what do we want to place our emphasis? A lot of times you look at the research and you can see that the developmental sequence allows for progressive weight bearing into the joint. So if you want to increase the stability of that joint. We want to increase the muscle activation around that joint. A lot of times weight bearing would be better than not weight bearing exercise. So it's especially important for that in the post-op population. And quadruped is a very good intermediate step to full weight bearing. So a lot of times you get them in a quadruped position, they can bear weight through their lower extremity, and then they can start with kneeling, half kneeling, and then they can progress to full weight bearing in that standing position. We also can look at the hip in a weight bearing position as being described as a socket moving around the ball of the femur. So you look at the head of the femur, how it moves in the acetabulum. Now we're looking at the acetabulum moving around the head of the femur. And also, too, we look at physics, right? Physics can help support this top-down approach, which increases levers and movements about the hip, increased torque that is produced by the weight-bearing hip. So a lot of times, too, we can increase emphasis of those hip musculature by using a top-down approach because of the longer lever arms that can be instituted with this exercise, and it's be a more of a functional exercise pattern that you can utilize. So what are we looking at here? We're looking at components of functional carryover. So what are the components of a functional carryover? These will individualize, right, and think about how the movement occurs, right? So again, this is important. We want to individualize our treatment plan and how that movement occurs biomechanically, right, and functionally, right? How do we pick something up? How do we throw something? How do we run, right? We want to train the body to perform functional movements without compensation. And that's the biggest thing that we do. A lot of times your athletes are very good athletes because they can compensate for their inconsistencies or their shortcomings with their muscular patterns or the movement patterns that they have. So this is something that we have to do early on. We have to groove motor patterns and movement patterns for the athletes to be able to not compensate for that and to be able to use the appropriate muscles in that sequencing that we want to utilize them for. Exercise types need to be incorporated into proximal focus programs to allow possible carryover of neuromuscular control of the lower extremity during activity. And that's important, too, as we talked about before, how we can train them to perform these activities, right, that they want to go back to. And this might not be just sport. It could be anything, activities of daily living. So a lot of times we want to balance our exercise programs, and they should include all of the following: neuromuscular control component, a weight-bearing component. We want to exercise in all planes. So we want to make sure that we're exercising sagittal, frontal, and transverse plane. We also want to do triplanar exercises with them. We want to do rotation and anti-rotation exercises. Eccentrics are a very important aspect of muscle strength and motor control, in my opinion. We want to incorporate speed variables. We want to make sure that we can do high-speed exercises, low-speed exercises with these individuals. A lot of times when they're going back to their performance or moving, we're not performing at the speeds that they are going to want to perform at and what they need to perform at. We want to do higher demand exercises, which could be a plyometric type exercise, could be jumping type exercise, can be heavier weights. So we want to increase intensity, increase that weights that sometimes we may not do or shy away from in a rehabilitation setting. So we want to make sure that we progress them and we increase the demand placed upon them so that they're able to return to their sport without any limitations. So what's the carryover evidence for the carryover? Well, strength training will improve power. We all know that. And the combination of strength and explosive training methods will improve all qualities of muscle power. And the assessment and training should have directional carryover and sports specificity. So these are things that we want to look at is design our exercise programs to finally, at the end stages, go over to what they want to do. What is their specific sport, or as I say, athlete specific? Because we can just design a football specific program or a basketball specific program. But if we don't design it towards that defensive back or that offensive tackle, those are two completely different rehabs or activities that you're going to be looking at. The same thing with a guard or a center. They're going to be two different rehabilitation programs or two different movement patterns that you want to address with those individuals. So direction-specific plyometric training effects can carry over into sport and performance tasks with similar force vector demands. And this is something we'll talk about a little bit later on, but it's also important to realize that how you train your athletes is important because that's what they want to do in the field. So if they're more a lateral-based athlete and need to do lateral-based work, we should incorporate laterally based training into the program. We want to increase force demands upon them in those directions. So either in the sagittal plane, frontal plane, triplanar motions, a lot of cutting activities, a lot of demands, and looking at the neuromuscular control when they do those activities. How are we going to progress their exercise? So we're going to look at where do we start from phase 1 all the way to phase 3, 4, whatever phases you want to apply to your athlete. It looks at a rehabilitation program should include isolated local strengthening. So early on, we want to make sure that our joints or our muscles are strong enough around those joints that are pathological, because we want to produce a solid foundation on which to build a regional and integrated exercise in later stages of rehabilitation and facilitate future performance. And this is key, that we want to make sure that we have the strength and the ability to do these other advanced exercises, and we have to have the mobility to do those as well. From the targeted exercises, we want to progress to regional exercises and apply the interconnected kinetic chain exercises. So there are going to be more movement patterns we're trying to groove with these individuals. So we're going to see what muscles are involved in these motor patterns and movement patterns and try to strengthen them and integrate them into a rehabilitation program. Again, rehabilitation may reflect the acquisition of a new movement or motor control pattern rather than changes in muscular strength. And a lot of times this occurs earlier on into that, where you increase the efficiency of that movement pattern, and then that muscular strength will come with it. So a lot of times if you want to make sure that they're doing their movement and motor control patterns correctly. So those are the things that you want to do, is you don't get compensation for them with that. And again, you want to establish a desired movement pattern during the warm-up. And that is very important. So a lot of times you can utilize your warm-up to establish the movement patterns that you want to incorporate into their rehabilitation program. So you want to warm those muscles up. You want to increase some neuromuscular control. You want to look at motor control when you're doing your warm-up patterns. So your warm-up should be very specific and tailored to that athlete that you're training. So what do we want to consider when we're designing our exercise program for that stability? We want to look at dynamic ligament tension. And we also want to look at dynamic stability that are influence of that. So if you look at things about that back functional line, we have the back functional line and the anterior functional line, so posterior and anterior functional lines. We have the Sharapi effect. We have those force couples. We have a kinetic chain ripple. And we have neuromuscular control. So these are the things that we should think about when we're designing our exercise programs, our rehabilitation programs, of how they come into interplay with one another, right? Especially that Sharapi effect, and especially with the kinetic chain ripple. You look at the kinetic chain ripple, it's like if you throw a stone into a pond, those ripples get bigger as they go out, and that can be a problem later on. So if I have a small problem up in that kinetic chain, more distal to that, there'll be a larger problem. A lot of times too, if you ever built a deck or anything like that, if I'm off 1 degree or one corner and I have a long lever arm, I'm going to be off a lot of degrees at the end of that other corner, and I'm going to have problems. So that's a lot of times. So if I'm off in one area in proximal, I'm going to be off in to a greater degree in that distal portion of that segment. And what are we going to look at? Dynamic stability influencers, all right? So we have weakness and fatigue can influence, right, our ability to stabilize our joints that we're looking at. Weaknesses, all right, muscle imbalances. So I have tight agonist and antagonist muscles. And I have injury, swelling, and surgery. These are all things that can throw off our kinetic chain. These are things that can throw off the ability to produce stability and increase our strength. So these are all things that we look at. And you can see the back functional line here, how they comes together all the way from the lat, all the way to thoracolumbar fascia, to your glute, getting all the way to the IT band, your vastus lateralis, down back into your hamstrings here. Same thing on both sides, how those lines cross and how sometimes you can work, you affect your latissimus dorsi and how to stabilize the low back with that tension to that thoracolumbar fascia. What are some of the muscle groups that come into play when we talk about proximal stability or functional stability as well? We can look at all these. We have the larger muscle groups such as your rectospinae muscle group, the latissimus dorsi, quadratus lumborum, your glutes, your iliopsoas, your sartorius, your adductors. Sometimes we forget about our adductors, about there being either hypo or hypertonic in regards to its effect on the other surrounding muscles. And then we can look at the small muscles, the hip rotator cuff, such as your external rotators, your deep six external rotators, the multifidi, the transverse abdominis, and your pelvic floor. The pelvic floor is basically the bottom of that tin or that cone when we talk about the core, and that's very important for hip movement or pelvic movement and stability as well, along with your deep six rotator cuff muscles of your hip. So if we look at the glute max, right? So glute max, we're not going to go over to a lot of this is for your information, but we can look at the different parts of it, and things that you should be aware of is to have a large attachment site, and it attaches into the iliotibial tract or the iliotibial band, a lot of times as much as 80%. So it comes into there, and it has an effect on that portion of the hip. And if you have IT band tightness, sometimes it can affect that as well. All right. There's a strong hip external rotator, 45 to 0 degrees of hip flexion because of its attachment to the trochanter and the linea aspera, and it's a very strong hip extensor. But sometimes we forget that it does have a strong connection with your IT band and into the iliotibial tract. It also has a connection to that sacrotuberous ligament as well. So if you're looking at some pelvic dysfunction, it can play a role in rehabilitation of that as well. We look at glute med, right? So we look at the three portions of the glute med with your anterior, middle, and posterior portion. All right, they're all basically equally in volume at the same size. The anterior and middle fibers run more vertically, which can affect your exercise, how you design your exercises for those as well. And the posterior fibers run more or less in the horizontal and are parallel to the neck of the femur. So the glute med is primarily a hip abductor, right? It plays an important role in the pelvic stabilization functionally, as we all know, with the Trendelenburg gait and with that during walking. So you look at the different types of fibers here. Here's your middle, anterior, your posterior part. So your posterior part more runs out horizontal to that hip joint. We also look at the deep six, which are very important too. So we look at the deep six hip muscles here, where they're coming from. Right? You have your piriformis, your gemellis, your obturators, and your quadratus that you have. A lot of times these are described as a hip rotator cuff, so they have very similar function as the shoulder rotator cuff does, trying to pull the head of the humerus in and stabilize that in to the acetabulum. Right? You don't want to slow down. They want to use it as a hip external rotator, right, and try to slow down the internally rotating femur, just like it does in the shoulder, similar to a throwing shoulder that you have. These guys are going to try to slow that down eccentrically. So it's important that we try to train our external rotators over our hip in the eccentric fashion as well. And they work as stabilizers of the hip. And it's a difficult muscle group to research because of the biomechanical modeling, and it's not an in vivo studies that you can get to these fairly well. Some of the research has pointed out that it does have similar effects as a rotator cuff in the shoulder. Look at the adductors, things that we look at adductors. Here's some of the important things that we want to look at is the adductors, all right? Maybe eccentrically controlling hip internal rotation of the femur, all right, during weight bearing and a loading response during exercise, right? It has a large contribution, right, in the transverse plane motions of the femur, and Padua et al. So that usually sometimes if you have a very tight or hypertonic adductor, it can cause you to have medial knee displacement during squatting tests. Again, we'll talk about the pelvic floor. All right, so here's your pelvic floor muscle. It's basically the bottom of that cone when we're talking about abdominal control in the core and the trunk. Turtle et al. Put healthy females to a hip exercise program targeting hip external rotators. After 12 weeks, a lot of weeks that they're going through their hip external rotation programs, right? They find an increase in hip external rotation strength, but also pelvic floor muscle pressure increased as well. So the strength of that pelvic floor increased. And this was they surmised as a secondary, right, for the obturator internus having the fascial attachments, right, the fascial attachments to that pelvic floor, which has been shown to help increase the stability of your trunk. So what should we think about? What do we have to determine, right? Can a hip-focused, right, or proximal control program, right, influence variables beyond just the lower extremity, such as human movement during athletic performance? In a study by Wiley et al., they published a study on hip strength. So they strengthened the hip abductors, hip external rotators, right? And they found no change in abnormal hip mechanics during running. So they did a lot of strengthening, but they didn't find it changing their performance in their running mechanics. So this data presented in the study suggests that strengthening alone may be insufficient to alter abnormal movement patterns of lower extremities during running. So we can look at this, maybe extrapolate this to other activities as well. And we have to determine how we can increase strength, but also increase function at the same time. So we can look at some developmental progressions. And things with the developmental progressions that we want to do is we want to make sure that all of these motions here, right, should be incorporating components of functional movement patterns, right, moving a desired motor or movement pattern for your athletes. So early stages of training can be supine, seated, sideline, prone, quadruped, and then the later stages of training can be tall kneel, half kneel, bilateral stance, unilateral stance, and then high intensity exercise, such as a low level plyometric or a plyometric exercise. But again, I want to emphasize that a lot of these components should incorporate some sort of a functional movement desired that you want to move into your patients, all right, to start them with that stability or movement that is going to lead to a proper progression of a movement pattern. So what are our best exercises, all right? Best exercises, should they be supine, sideline, standing, or seated? High intensity, low intensity, isolated, or integrated? We have neuromuscular, strength emphasis, weight bearing or non-weight bearing, weighted or unweighted, static or dynamic that you want to do. So we can look at all these variables. So in the next few slides, we're going to go over some of the research that shows that some of the exercises might be best for a hip or for the trunk when we talk about exercise. So if we look at high intensity and low intensity exercise with your individuals, all right, in a study by Sebastian Baum et al., looked at lower motor control intervention and high intensity that you have. So they found that lower motor control intervention may result in superior outcomes in activity, movement control, muscular endurance compared to high intensity or high load intervention, but not in pain intensity, strength, or endurance. And high load intensities are more effective, right, compared to lower intensities to produce adaptive responses. And you can see the effect sizes of the muscle contractions that they studied, and the eccentric effect size was highest, not much greater, but it was higher too. So what this tells you is that, what tells me is that you may want to start off with a lower motor control exercise and then progress to your higher level, the high load intensities, so you can get the best of both worlds with this. So you just don't have to do one or the other. You want to integrate both of these into your program. So if we look at exercise positioning, what's the best position for these exercises? In a study that was done, you can look at here, standing, sideline, seated, and where most of the EMG activity were given from these individuals. All right, so you can look at a study by McAdam. They found that both glute max and glute med in the standing position produced a higher activation compared to sideline position. And the seated position produced the highest average activation for glute max and glute med. A lot of times we don't do these in the seated position. A lot of times we'll put them in a clamshell on a sideline or standing position. So this might be interesting that we start them off in a seated position to get some more strength gains maybe, and then progress them to a sideline or standing position. In a study done by McAdam also, they looked at 39 studies, right, in a systematic review. That 25 exercises were performed in the vertical vector. They looked at 14 exercises performed in the horizontal or anterior posterior force vector, and they looked at 38 exercises that were included in the horizontal or posterior anterior vector. And the best exercise, right, for the vertical vector was a single leg wall squat, which you had 86% of MVIC for your glute max. If you look at the highest for single leg squat or single leg bridge in the anterior posterior vector was 54% of their MVIC. And from the posterior anterior, I looked at a plank with a bent leg hip extension at 106% of MVIC. So this might give you an idea of where you can start with your athletes and the different types of positions you can put your athletes in with your glute max during body weight exercises. Now, if we look at weight bearing versus non-weight bearing here, weight bearing exercises produce a greater percentage, right, as compared to non-weight bearing exercises for both glute med and glute max. The glute med activity levels were higher than the glute max in both positions. The top 3 glute max and top 2 of the top 3 glute med exercises were performed in the weight-bearing position. The authors concluded that standing exercises impose a greater demands of muscular, and changes to the base of support can affect the activity level of the glute max and glute med. So this is something that we should look at, is we should get them to that weight-bearing position, right, and incorporate that into their training program as best as we can. Now, that doesn't mean we can't use a non-weight-bearing. We can use a non-weight-bearing mainly as a warm-up and then progress them to a higher level or high-intensity weight-bearing type of exercise. We look at glute medius exercise in non-weight-bearing, right? The highest one there was a side plank with hip abduction for those individuals. You can see how the other exercise here where they average percentage, right, for glute medius with this. They're all fairly higher, so they ought to be all considered fairly high into their MVIC for that glute medius activation. Here's a glute medius activation in weight bearing. You'll see here that the contralateral split squat was the highest with that, and the contralateral walking lunge was highest with that as well. So these are the 2 exercises that you can look at for glute medius activity. Again, now on weight bearing exercises, that's here, right, that causes them to function or fire the glute med. We all know, we talked about Trendelenburg gait, the effect of the glute medius on that. And also, too, sometimes we forget about the effect on the quadratus lumborum on that opposite side. So if you look at the opposite side here, it puts a lot of strain on that quadratus lumborum, which again might affect lumbar dysfunction in those individuals. So you look at the pull and the force vectors of that glute on the effect of the pelvis when we're looking at here. And it can also stretch that IT band out a little bit. So pelvic obliquity in this relationship is very important when we talk about normal mechanics and function with your athletes, especially with running and jumping, right? This comes into a big, plays a huge role in that. We can look at the glute max or glute max here. You have your superior portion and the inferior portion, right? The superior portion is more active than the inferior glute max during hip abduction and external rotation because of the line and the pull of that. And then you can come down, you can see where the IT band comes in to play there. But you see the 2 superior and inferior aspects of the glute max and how it can affect their, the exercises can be emphasized. Things that you can utilize too early on with a glute max to help control pelvic stability and maybe glute max. I like walking them here. You put them in a weighted position, so you're pulling down on them, and you can use a single leg stance. You're just walking, or you can just get up on their heels and have them shift their weight back and forth. That puts a lot of activity into their glutes. If you've never done this, try it. It's a good exercise. You can also do this type of exercise, just the hip hike. You can put a band around down here and have them pull against the band if you wanted to do that, or add a weight to that as well, more so than just your lower extremity. You can see that I'm utilizing both my quadratus lumborum. As I said, we forget about the quadratus lumborum a lot with these types of problems, this pelvic obliquity type problems. Now you can see how the glute medius will pull down and make that pelvis more level again. But these are 2 good early on exercises for your athletes or even for any type of patient to do. Hip hike is another easy one that you can do with just the ball against the wall here, right? You can see where your targeted muscles are. You can see the line of pull, or that line of pull from that glute is right with your IT band as well. We look at glute max activation from Sulkowitz, right? In 2016, you can look at the best for the superior glute max, best for inferior glute max, and then the best for both. Best exercise for the superior glute max is a clamshell, unilateral bridge, and a quadruped with hip extension with the knee flexed. The best for inferior glute max was a unilateral bridge, quadruped with hip extended, right? And the quadruped with hip extension, right, with the knee extended or with the knee flexed. And best for both was a unilateral bridge and then the hip extension with the knee flexed and the knee extended. So these would be your top 3 exercises that you could do for both glute max, the superior and inferior portion of your glute max. Another one that we can look at is glute max activation. The needle, right, was back squats, right, deadlifts, hip thrusts. They looked at all of those, right, and looked at the best mean activation of your glute max. And they found that step-ups were the best for all of those, all right? So you look at the step-up was highest, 125, all right, percentage of MVIC. And the minimum MVIC, minimum the max was very high as well, you can see there. So hip thrusts were fairly good too, but those step-ups were very, very good with them. And then also in the same study, you can look at what was considered very high exercise, a high exercise, right? So all of these here, right, high to very high. So your step-ups, XSPI deadlift, rotation barbell hip thrust, traditional barbell hip thrust, American barbell hip thrust, belt squat, split squat, inline lunge. All of these have been found to have very high or high MVIC that you have. Interesting down here are your squats. They're very low. He said moderate, but comparison, they weren't as much as your other exercises. So these would be the exercises that you probably should concentrate on if you want to get some glute max activation out of your patients. Also with your glute max, right, it was from the same study, it was shown that there are several factors, including relative load, velocity, level of fatigue, mechanical complexity of the exercise, the need for the joint stabilization may directly influence glute max activation. So these are things that we have to talk about, right? You should incorporate or think about when you're incorporating these into your exercise program. How much load do I have to do, right? How fast am I moving them, okay? What's the mechanical complexity of the exercise and how much stabilization do I need? Also, Kang et al., right, found a patient in foot at 30 degrees of hip abduction presented higher glute max activation and 15 or 0 hip abduction during a body weight hip bridge. So it's your hip thrust or your hip bridge. Barbell hip thrusts elicit a high and very high glute max activation even when relative low loads are lifted. And that's important to remember that even when low loads are lifted, you get fairly high activity of your glute max with the hip thrust or a hip bridge. If you look at another study, that they used 40% of the 1 rep max, they obtained a high and very high levels of glute max activation and variations of the hip thrust that were investigated. And Delgado et al. Observed that the barbell hip thrust, right, performed with 60 kilograms, which is 36% of the 1 rep max, elicited similar glute max activation, right, than what they found with the Romanian deadlift and back squat at the 1 rep max. So you look at 36% or 60 kilograms, right, which is about 132 pounds. That isn't that very much for a hip thrust. And they found that they had very high levels of activation with that exercise during that hip thrust. When you look at that in Clonzo Garcia here, right, as I said before, had very good activation with hip thrusts, right, when they're doing a very low loads at your head. So hip thrust would be good to start off with, or hip bridge could be start off with to get that glute max activation without adding a ton of external weight to them. This is a nice exercise here when you look at that for that hip extension. So you put them in a plank position or in a straight leg deadlift that you have, or single leg RDL. It's nice. You put that band around your arms or any tie it down and have them extend their hip. So you can do a hip extension that way, and then they can raise it up as well to provide more of a hip extension. You also have to stabilize the pelvis here through the core, and also you get that stability through the shoulders as well. So these are exercises that I like for my patients or for your athletes when I'm doing their integrated exercise programs. So I can get their shoulders involved with that. I can get their trunk involved with that, the hip, right, in the pelvic region, all the way down here. I'm also getting some stability here on this bottom leg as well. So I'm working the top leg as well as that bottom leg or the weight-bearing leg with these exercises. So I like this exercise to begin with. And you can do this without weight as well to begin with, and then you can just start with adding tubing with them as well. Here's an example of that hip bridge. You can see those muscles that are involved in there. And this is another exercise that you can utilize to put a band around them. You can put a TheraBand around there, all right? And this will help increase the activity of your superior portion of your glute max for these types of exercise. These are like hip thrusts and I like hip bridges for hip musculature activation. And then you can do your glute march. All right. Again, these are nice exercises to integrate the whole thing here. Things I'll have my athletes do, I'll have them push down into the ground with their arms. So the reason why I do that is help activate that shoulder extension. We can activate the thoracolumbar fascia and help support the lumbar spine. And I can get that nice hip extension. I don't want to really get back extension. I'm looking for hip extension. I don't want that. So that's why a lot of times I'll have them push into the ground with their shoulders to get that lat activation. Also, too, is when you can look at if I have my feet narrow or wide with that. A lot of times it's easier with their feet together to get that hip extension because I'm changing that angle, right, of that hip in that socket a little bit to make it easier for them to get that extension from their hips, right? Again, it's important to get the extension from your hips and not your lumbar spine when you do these exercises. Another exercise that I like is called a kneeling hip thrust. And again, you come back, you can do it with tubing, or you can do it with a dowel, right, with a pulley machine or cable machine, or a dowel with a tubing with your exercise bands around there. And then you sit back and you just pull forward into that, really squeezing at the top. And you can also, too, you can put your feet more in a triangle. Again, you want to feel it more in your glutes, and you shouldn't feel anything in your lumbar spine at all. If you feel any lumbar spine, you're going to have to modify their hip position a little bit or tell them to concentrate on pushing through their hips more so than in their lumbar region. We look at a top-down versus bottom-up test that you can do to determine where they have the excursion in their hips, and you can just use like the SVT testing device how far external rotation I can get on that weight-bearing hip or that internal rotation. And then you may be able to determine if they have deficiencies in their hips that you have to work on later on or address. So you look at that external rotation in that stance leg, that internal rotation on that stance leg, and compare side to side. It's a real easy way to see if you have deficiencies from rotation. Top down versus bottom up exercises. This is stuff that I really like to do with my patients here, is that you look at, instead of rotating open chain external rotation here, I want to do the airplane exercises for hip stability. This is also great for trunk stability and glute max, glute med activity that you're looking at with these individuals. So an airplane would just be you get them in a single leg RDL here, and then you open them up. So you open their hips up, so you get that external rotation into that way. And then you just come back over and you get yourself parallel to the ground, and then you open up again. You can do that with weight. If you want to put weight in this hand, you can do that as well. You can also do it against tubing if you have the ability to do that. It takes a lot of stability to do these exercises, but if you needed to, you can have them hang on to something overhead, and they can just start with moving their hips in regards to their plant leg when you do that. So you can't stabilize them. They can hold on to a chair or to a bench or even to a band if they need to. Another type of top-down trunk rotation effect on the hip, right? Again, you're going to be using all of their, like a ball toss against the wall. You're going to get that external rotation in this back hip. You're supporting yourself through your core stabilizing muscles here. So you'll get your core stabilizing muscles in there, your quadratus lumborum coming off there. You're going to get your obliques here. You're going to get your glutes. So when you get that rotation, that pelvic rotation, you're going to get all these muscles involved in there. You're going to get your hip rotator cuff muscles involved with that. So you can do that with a pulley system where you're pulling off here, where you're rotating your body, and then your trunk will rotate the opposite way. And same thing with the med ball, or even just a tubing rotation exercise that you can do for your athletes. One that I like is the rotational landmine press. And this is nice because, again, it's another total body exercise that you can do. So trying to prevent, right? Trying to promote rotation, trying to prevent integration of that upper chain, right? And that functional line in the lower pattern here for the lower extremity. You will work on your glutes, right? You get some quad, you'll get some erector spine in through there. You'll get stability of your core, your trunk. With these, you can progress from a half kneeling, tall kneeling to squat into a lunge position with your athletes. And as I said, I like the landmine exercises. You don't need a landmine to do it. You can do it with a piece of tubing that you want to, or exercise bands that you can utilize with your athletes. Another way you can look at things, right, is a banded rotation for hip external rotation. Again, this is part of your top-down approach that you can utilize versus a bottom-up. So this is more of a bottom-up approach here, right, this way, where I'm trying to control things from the hip. I'm working my hip external rotators from the bottom, right, up, versus a top-down approach where I'm looking at progressing that exercise here. Now I have to control, right, so I'm incorporating my trunk in there, right, I'm incorporating my pelvis here, and then my hip all the way down in through there. Now also too, I can do these exercises where you can open up and support them. Then you can also add a jump to these, right? So I can put you in this position, add a jump. So now I'm increasing that intensity. I'm increasing that eccentric load on these individuals. And a lot of times too, you have to increase that eccentric load from this so you can work these eccentrically as well. It's the same thing with your airplanes. You can work those very well eccentrically, control it on the way down. You can also increase speed of those as well. But this is a nice exercise for your patients. Try these if you haven't done these already, with that top-down versus that bottom-up approach with your athletes. Help working that lumbo-pelvic hip complex and get it all integrated in there. Other ones that you can utilize is a rotational squat. You can see how that would affect on that lunge. That rotational lunge, you'll get that extension, that external rotation, but you're also going to get that serape effect and that functional back line all the way through there that's going to be activated with these individuals. That rotational squat can be the same thing where I'm coming down in one direction and I'm rotating back up. And depending on where you hold that weight, can help stimulate that erector spinae muscle group. It can help stimulate your trunk, all those trunk muscles, important for your core stabilization when you're trying to transmit those forces from the lower extremity to the upper extremity and vice versa. We all love the clamshell. We do the clamshell a lot with your athletes. So the target muscles for the clamshell, right, would be the superior portion a lot of times that you're going to have in hip external rotators there. And a lot of times you always do the clamshell, a lot of times in a seated position. I mean, not in a seated position, but in a sideline position. You may want to think about seated position, as we saw from the information from their research earlier. The inferior portion is active, primarily as a hip extensor. And then exercises that primarily involve hip extension target both portions of glute max similarly. These are good here. These are some things that you may want to utilize as a warm-up for your athletes. So if you utilize a clamshell as a warm-up, that would be good in different hip positions. And these slides will show you some of the different positions that you can utilize for your glute max or your clamshells. And a lot of times, too, you want to make sure that the pelvis stays stable. You can do it in multi-angles of hip extension and external rotation. And again, use it as a warm-up to focus on endurance for your athletes. So this would be a great warm-up exercise for individuals who you want to progress to higher level exercises later on during their warm-up or during their rehabilitation sessions that you have with it. So I like these as warm-up exercises. You can also do reverse clamshells, so on and so forth, with tubing here with this. And I like doing this tubing by working on the eccentric portion of it. I can put them in a tall kneeling or half kneeling position, a quadruped position, a prone position, right, and even a seated position that we talked about. So a lot of different positions you can put them in. And I would emphasize that you could put them in, again, as a warm-up or as variation. So one day you might do the tall kneeling or the half kneeling, and the other day you might do the quadruped position, adding that weight-bearing component into there, both of them. So now we're both weight-bearing in that quadruped and that half kneeling position. I want to do some concentrate a little bit more, maybe more on faster eccentrics, right, to slow that down at the very end range. You can put them in that prone position and doing something like a reverse clamshell if you really wanted to do something like that. Another nice glute max and adductor activity, put that ball against the wall, have them extend their hip and raise that ball up and down. And also too, the ball into the wall is another one for stability. Some people will do this as well. If you look at your Posture Rotation Institute individuals, they'll put you against the wall in a prone position, laying on your back, and have you push into the wall with some of those exercises that they have you do with that. These are similar, but they're just in a different position. So I have a nice push that hip into the wall and come up in there, all right? And same thing here, I'm pushing that ball and lifting that ball up and down with that leg. Other things that you can do here, again, we're looking at the bottom down approach versus the top down approach or bottom up approach here. I like this. You can do this a little bit too. You get that rotational disc in there. The things that you want to do for your athletes are right, tell them to grip the floor with their great toe, screwing the hip right into the socket as they turn out. You can also do these exercises with the band around their trunk as well, which would be interesting to do with you guys when you guys try it. So put that band around their trunk and can do this. You can also do that with a straight leg RDL as well. Then you can progress to different ones. I like doing the band exercises down here, the longer lever arm, right? Because then I can work on that external rotation with my ankles. A lot of times I'll put them up maybe a little bit further here around the metatarsal legs that you utilize. So just you can progress them. This is a good progression that you can utilize here when you're in that weight bearing position, you're doing your monster walks, so on and so forth. Here's another exercise again from that top down approach. I'm trying to put them almost in a runner's position. So if you have a runner, you can put them for stability and you go into that proper sequence. And if I wanted to, I could also add weight by tying a band here around the foot and have them pull up into that position. So these are things that you want to look at. So we're looking at this stance leg here, right? How will I control my pelvis when I'm swinging my leg through? And I can do this in varying speeds, right? And varying degrees of knee flexion that you can utilize. So if you look at the back functional line, right? We talked a little bit about this before, how this is important when it all comes together. And that's the basis of this talk a lot of times, is looking at the effect that the body has on one another. That if I can tighten things up here, if I can tighten my lat, it'll affect my thoracolumbar fascia, it'll affect my glute, it'll affect the posterior chain down the back here, all right? So it helps with that stability in there. But again, if I have problems up here, it might create problems down here. So I have to look above and below that chain there with that. So a lot of times if I'm doing a row here, if I'm doing a row here in this position, it's going to affect my lat, my shoulder extensions, but also then I have to stabilize my pelvis, right? I have to stabilize my core, and it can all the way down there. So it can be that functional line exercise, which is very important. So if you look at those, and again, if you look at Thomas Myers anatomy trainings, this is similar to that. Posterior functional system progression, how we can progress these individuals. Quadruped with shoulder pulley or band, hip extension, half kneeling, split squat, and then step up with shoulder extension. So these are some exercises that you can do with your athletes and your patients that will progress them from one to the other. But again, you want to make sure that they're not compensating and they're doing these in the proper movement pattern and motor pattern that you want to groove for them. A couple different exercises that you can do: lunge with shoulder extension, where you have that pulley come down. Again, look at that, how they integrate with one another. Another exercise I love a lot is the deadlift. A lot of people are afraid to teach the deadlift, but this is a great exercise for you if you have to pick something off the ground. Again, a deadlift is basically a hip hinge. That's all we're talking about, how we're going to use that hip hinge, and that shoulder should be for a little bit in front of the bar. Things people get in problem with the deadlift, they get their hips too far back and the shoulders too far up, and they don't get their shoulders far enough over the bar what they want to lift. You just teach them like a hip hinge would, and then you'd be set. This is a great total body exercise, is the deadlift. Another one for this would be battling ropes. Great exercise, battling ropes with a lunge. It gets all your shoulders, your trunk, your lumbopelvic hip complex, and your lower extremity as well. So this is a great exercise when you do your battling ropes, and you can utilize that with a lunge or with a lateral lunge or with a forward or backward lunge as well in those positions. Another way you can do this too is a stand to squat with rotation. And this is very good as you use as part of your warm up. So you can stand, squat, and then rotate either leg to side, or like either arm side to side, and you can see some differences. This would be a good assessment tool that you can utilize for your athletes as well. You can see where they come in to play with their thoracic rotation and their hip motion here. So a lot of times you can utilize this as a warm-up exercise for your athletes. Example pairings that you can utilize: you can use a deadlift with a dowel hip hinge. So in between every deadlift, you're going to use a dowel hip hinge against the wall which will help with that grooving, that motor pattern for that deadlift. You can do reverse lunge with a hip flexor mobility drill in between that. Use a hip thrust with shoulder extension and clamshells that you can utilize, and a banded squats lunge with shoulder extension. These are all pairings that you can utilize with your athlete to incorporate that total body exercise program. And other exercises that you can utilize here, banded squat with, and this can be not just around the knees, but around the trunk as well. So you run it from the feet all the way around the body, just like sort of we did with that single leg one, but now you're stepping on it. You're stepping on the band, so not like rotation. So you're going to do that lunge with rotation, squat with rotation, landmines, jumping and landing exercises. And these are all important to look at, incorporate into your program. So a lot of rotation, a lot of triplanar exercises that you want to do that, get those directions, exercises in all those planes, and then add jumping and landing exercises. These are very, very important to utilize into your programs. Thank you for your time. And if you have any questions, you can reach me at the University of Virginia, and the references will follow into there. So thank you very much, and hope you have a great day.